My name is Tony Avellino, and I will talk about cerebrospinal fluid devices from Chapter 229. In this talk, I will outline 5 areas. Number 1, hydrocephalus. Number 2, cerebrospinal physiology and fluid flow physics. Number 3, historical background of hydrocephalus treatment. Number 4, ventricular shunts. And number 5, shunt malfunction. The incidence of pediatric hydrocephalus as an isolated congenital disorder is 1 per 1,000 live births. There are 69,000 hospital discharges each year pertaining to hydrocephalus. We spend $1.4 to $2 billion of our national healthcare expenses per year for pediatric hydrocephalus treatment. What is hydrocephalus? It comes from the Greek word hydro meaning water, cephalus meaning head. It's the abnormal accumulation of cerebrospinal fluid within the cavities called ventricles inside the brain. On the right, you will see a non-contrast axial section of a head CT scan of a child with hydrocephalus. And note that the ventricles are quite enlarged. Hydrocephalus can be caused by impaired absorption of cerebrospinal fluid or overproduction of cerebrospinal fluid. For those causes of hydrocephalus where you have impaired absorption of cerebrospinal fluid, it could be due to congenital reasons, after intraventricular hemorrhage, after an infection, tumor-related, aqueductal stenosis, Arnold-Chiari malformation, and Dandy-Walker malformation. Cause of hydrocephalus where you have overproduction of cerebrospinal fluid is in a child that has choroid plexus papilloma. Why treat hydrocephalus? Well, as you can see on the right side, I have 2 axial head CT scans. The one on the top shows a child that has hydrocephalus in which the ventricles are enlarged. And the image below that is a same child that had a ventricular shunt placed, and you note that the ventricle size is much reduced. So when you have hydrocephalus, you have increased pressure within the brain. So you want to decrease that ventricular size to decrease the pressure and decrease the compression in the surrounding brain cells. Because if you do not do this, this could lead to brain injury such as impaired cognitive development and impaired motor abilities. Next, let me talk a little bit about cerebrospinal fluid physiology and fluid flow physics. As one knows, the ventricular system inside the brain contains 2 lateral ventricles that drain into the 3rd ventricle through the foramen of Monroe, and that drains into the 4th ventricle through the aqueduct of Sylvius. And then the cerebrospinal fluid flows out the foramen of Magendie, circulates down into the subarachnoid space around the spinal cord, and then circulates back up and gets reabsorbed through the arachnoid granulations. So in the brain, the choroid plexus, ependyma, and other cells produce cerebrospinal fluid. And then the cerebrospinal fluid is absorbed through the arachnoid granulations. And you can see on the diagram on the right side that CSF flows from the lateral ventricles into the 3rd ventricle, into the 4th ventricle, then through the foramen of Magendie into around the spinal cord subarachnoid spaces, and then circulates back up and gets reabsorbed through the arachnoid granulations. The volume in an adult, we have about 150 cc's, but only 15 to 25 cc's are in the brain ventricles, and the other is in the subarachnoid spaces. Neonates, however, have a total volume of about 40 cc's. In adults, we produce about 20 cc's per hour of cerebrospinal fluid, which is about 0.34 cc's per minute, or about 500 cc's a day. This slide shows how the arachnoid granulations on the right side absorb that cerebrospinal fluid. For someone to understand cerebrospinal fluid devices, it is important to know about fluid flow physics, pressure, flow, and resistance. Pressure is force per unit area. For a cylindrical column of fluid, as in a shunt tube, the pressure at the base of the tube is equal to the weight divided by the tube's surface area, which is equated with the height of the column multiplied by the density of the fluid and the force of gravity. Pressure is usually expressed in millimeters of mercury or centimeters of water, whereby 1 millimeter of mercury equals 1.36 centimeters of water. Flow in a tube is defined as the volume of fluid passing a point in space during a given time. Flow from one end of the shunt system to the other is defined by the equation Q equals change in pressure divided by RT plus RV, where change in pressure is the difference in pressure between the ventricle and the distal catheter location. RT is the resistance of the tube, and RV is the resistance of the valve. So resistance to the flow of fluid through a shunt system depends on several factors. Because flow of fluid through catheters is laminar, resistance of catheters is defined by Pasolini's law, as noted on the equation. If you take the principles of fluid flow physics that we discussed, there's a pressure gradient in a ventricular peritoneal shunt. And the diagram on the right shows a child that has a ventricular peritoneal shunt in the upright and vertical position. And you can determine the change in pressure, which is equal to the interventricular pressure plus the PGH, minus the opening pressure of the valve, minus the intra-abdominal pressure. Thus, in the upright position, the predominant influence on the pressure gradient, and therefore cerebrospinal fluid flow, is hydrostatic pressure and not opening pressure of the valve. Third, I'd like to discuss the historical background of hydrocephalus treatment. In 1896, Henle attempted an internal cerebrospinal fluid drainage from the ventricle to the subgaleal space, but this valveless device was only rarely effective. However, currently, in neonates that have post-hemorrhagic hydrocephalus, we routinely place a ventricular to subgaleal shunt, and the skull x-ray on the right shows a child that has a ventricular catheter in the right frontal region hooked into a Rickham reservoir that strains into the subgaleal space, and you can see that the subgaleal swelling is noted. In 1918, Dandy performed a choroid plexectomy to reduce cerebrospinal fluid production. And in 1922, Dandy performed a third ventriculostomy. Until 1950, these were probably the most common procedures undertaken for infantile hydrocephalus, but success remained limited, and it was largely abandoned by the 1970s after reports of high failure rates. Interestingly, there has been a resurgence of interest in ablation of the choroid plexus, particularly when combined with endoscopic third ventriculostomy, and its efficacy may have been underestimated. In 1939, Torkelson performed a ventricular sternostomy, that is a rubber tube from the lateral ventricle to the cisterna magna, for obstructive hydrocephalus that was moderately successful. In 1949, Matson described a shunt from the lumbar subarachnoid space to the ureter with a polyethylene tube, which became popular in the 1950s. However, this procedure required a nephrectomy and was complicated by hypochloremic alkalosis, which was frequently fatal, and with the introduction of a valve shunt system, this technique was abandoned. In 1942 to 52, the advent of the modern cerebrospinal fluid shunt device was heralded by the publication of Nelson and Spitz paper describing a ventricular jugular shunt with a ball and spring differential valve. On November 7, 1955, Casey Holter was born with hydrocephalus and a myelomeningocele, and his father, John Holter, who was a machinist, developed the first silicone Spitz-Holter slit valve for his son. At approximately the same time, Prudence and colleagues also designed both a distal slit valve and a sleeve valve, both differential pressure silicone valves for use in ventricular atrial shunts. Silicone has since become the material of choice for implanted shunts since it is more biocompatible compared to polyethylene, which was not biocompatible. The initial preferred site for shunt placement was the vascular system. However, because of the risks, particularly of infection and associated shunt nephritis or pulmonary hypertension, and the identification of the peritoneal cavity as a suitable site for a cerebrospinal fluid absorption, the peritoneum became the preferred site for distal catheter placement. The outcome of hydrocephalus is an important question that parents often ask us. Well, how is my child going to do? There was initial landmark study by Foltz and Shurtleff in 1963, in which they had a 5-year comparative study of hydrocephalus in children with and without operation. And you can see that in Table 6, the mortality rate and autopsy percentages were compared in children with and without operation. And you can see that the group with an operation, 65 patients, there were 15 deaths, or 23%. In the group without an operation, there were 48 patients, and there were 22 deaths for a death rate of 48%. So truly, shunts save lives. The Foltz and Shurtleff paper from 1963 was based on pre-CT era data. However, in 1966, Shurtleff also published a paper in children that had meningomyelocele and associated hydrocephalus, and if their initial cortical mantle was less than 1 centimeter, they had very little function later in life. Young and colleagues in 1973 published a paper where they showed that IQ was related to ultimate frontal cerebral mantle, in that after a shunt was placed, if the frontal cerebral mantle was 2.8 centimeters or greater, then their IQ approached the normal distribution pattern. It should be noted that early valve-regulated models had a high incidence of distal obstruction secondary to an inflammatory response of peritoneum to the polyethylene tubing. This is important to know because the development of silicone rubber polymer in 1968 really led to more reliable shunts because silicone rubber is more biocompatible. The early models of shunts that didn't have valves led to rapid ventricular decompression, and if you rapidly decompress large ventricles, the cerebral cortex pulls away from the dura, and that results in subdural hematoma formations. Like I said, in November 7th, 1955, when Casey Halter was born with a myelomeningocele and hydrocephalus, in which his dad developed really an innovative valve, and his dad was a machinist, and that really changed the development of shunt hardware. Next, I'd like to discuss ventricular shunts. There are a variety of ventricular shunts, depending on where the location of the distal catheter is. You can have a ventricular peritoneal shunt, in which the catheter is into the peritoneal space. You can have a ventricular atrial shunt, in which the catheter is in the atrium. You can have a ventricular pleural shunt, in which the catheter is into the pleural region. You can have a lumbar peritoneal shunt. And also, as children grow up and they run out of other places where to put the distal catheter, people have tried ventricular to gallbladder shunts as well. A shunt consists of three components. The first is a ventricular catheter, the proximal limb, that is placed into the ventricular system. The second is the valve that regulates how much cerebrospinal fluid is drained. And the third is the distal limb, which is either placed in the peritoneum, atrial, pleural, or another area. The diagram on the lower right is an outline of a valve, and you can see there's a reservoir in the middle, and there's a whole host of different valves, which I'll go through next. And you can see on the X-ray on the lower left shows that valves come in and catheters come in a variety of shapes and sizes. The ventricular catheters come into a variety of shapes and sizes, as shown on the diagram on the right. Distal tubing, or the tubing that goes into the peritoneal space, consists of a tube, and at the end of the tube you can either have slit valves or a single hole. Also, there's a whole host of connectors that come with shunts, as shown on the diagram on the left. You can have straight connectors, right angle connectors, three-way connectors. In addition, you can have reservoirs that get connected into the valve, such as a Rickham reservoir. This slide shows the components of a shunt. On the right side, you can see a chest and abdominal X-ray with the distal catheter going into the abdominal region. On the left side, you can see on the top there's AP and lateral skull X-rays, which show the catheters in the brain with different connectors and valves. And the lower pictures on the lower left show an axial head CT scan that shows a child that has hydrocephalus, and then after a ventricular catheter is placed, the ventricles are decreased in size. Shunt valve mechanics. Valves are mechanical devices that regulate flow. There's three categories of valves. First is there's a fixed differential pressure in which they maintain the same differential pressure regardless of flow rate. There's flow regulating valves, which maintain the same flow rate in the face of changing pressure differentials or patient position. And then there's a programmable valve, which is the newest valve, which allows external incremental outflow adjustments without repeat operations. There's a whole host of fixed differential pressure valves, as outlined on this slide. There's a whole host of flow regulating valves, as outlined on this slide. And the newest valves are programmable valves, which have really revolutionized the management of shunts. And some of the programmable valves are outlined on this slide. Two programmable valves that I like to highlight is the Codman-Hakim-Meadows valve, as outlined on this slide. On the left slide, they come in a variety of shapes and sizes. In order to program the valve externally, you have a programmer. On the left side lists the programming unit that is an electrical unit that plugs into the wall. And on the right side is the programming unit. You can see that the valve comes in a variety of settings from 30 to 200 millimeters of water. And if you press the button, align the programmer on the valve, you can change the valve externally. There's also a Medtronic Strata valve, which does not need electricity but works by magnetic forces. And the valves come in 5 different settings: 0.5, 1, 1.52, and 2.5. The ranges from 15 to 155 millimeters of water. With the Medtronic Strata valve, you have a locator tool, an indicator tool, and a magnetic adjustment tool. Last, I like to go through shunt malfunctions, because shunt indeed saves lives, but shunts are mechanical devices and they do break down. This is an algorithm to guide radiographic and clinical assessments of a potential shunt malfunction. On the right side is an algorithm that highlights. So if you have a child that has a shunt and they present with the shunt malfunction, in an infant you can have increased occipital-frontal circumference, you have a tense and bulging anterior fontanelle, the cranial sutures are splayed, you may have impaired level of consciousness, irritability, emesis, dilated scalp veins, impaired upgaze, and cranial nerve 6 palsy. In older children and adults, they present with a shunt malfunction if they have headache, nausea, vomiting, impaired level of consciousness, irritability, papilledema, visual changes, or gait change. There are a variety of ways to diagnose a shunt malfunction. History, physical exam, you can get shunt series x-rays to see if there's any disconnections. You can have a head CT, MR, ultrasound, which checks if the ventricular size has increased or decreased. You can tap the shunt for the pressure or if you're concerned about infection. And there's also a radionuclide shuntogram that one can obtain. The history is really important, because if I have a caregiver or a parent that they tell me that the same signs and symptoms that their child is presenting to today is the same as when the shunt failed in the past, then that is very important to me. Over the last 10 years, there have been concerns about X-ray radiation of children undergoing multiple CT scans. Thus, the MRI manufacturers have developed new sequences and protocols that enable MRI scans to be done with a lot shorter duration, and you can get a nice image of the ventricular system to see if it's increased in size. This is a slide showing a HASTE MRI scan on the left and a CT scan on the right. You can see that the ventricular size on the HASTE MRI scan is just as good as a CT scan. Thus, when a child comes in, if we can get a fast sequence MRI scan, that's a preferable nowadays to multiple CT scans. A radionuclide shuntogram also can be done, in which a radio tracer is injected into the valve to see if the shunt flows or not. This slide shows that when you do a shuntogram, you put a needle into the valve, you can see if the pressure is normal. You can see if cerebrospinal fluid flows out of the needle hub. And you can also see after injection of the tracer to see if it clears out of the reservoir and gets dispersed into the distal limb. And on the right side is a diagram from one of the initial papers in 1974 describing the use of a radionuclide shuntogram in evaluation of a cerebrospinal fluid shunt. However, shunts are mechanical devices and they do break down. You can have disconnection at any piece in any site. You can have obstruction by debris of the proximal ventricular catheter valve or the distal catheter, and also you can actually have an infection. So this slide shows the shunt complications that can occur. Lastly, shunts truly saves lives. And if you have a child that comes in with acute shunt malfunction in extremis, you can truly save someone's life by paying attention to their airway, breathing, circulation. You can tap the shunt, in which you put a 25 gauge butterfly needle and remove a large amount of cerebrospinal fluid until the patient wakes up. You can intubate, hyperventilate, you can use mannitol, Lasix, hypertonic saline. You can sedate, you can use paralytics, but ultimately you need to take the child to the operating room. So if you have a child that presents with a shunt malfunction, it's important to urgently take them to the operating room to explore and fix what's broken. Postoperatively, we sometimes obtain a head CT scan if we're concerned about bleeding or ventricular size. We get a shunt series x-rays if we're concerned about any shunt component concerns. And we keep the patient on 24 hours of intravenous antibiotics. So I hope this talk outlines some of the important principles of cerebrospinal fluid devices. Thank you for your attention.